If you're sitting in your Gujarat University MD anesthesiology Viva, right? And the examiner just leans across the table, looks you dead in the eye, and asks you to describe rebuilding a running high-performance V8 engine,
Oh boy, yeah.
but doing it through the car's tailpipe.
That is exactly what it feels like.
Right. I mean, you are essentially talking about minimally invasive cardiac surgery. Welcome to this deep dive, by the way.
Glad to be here. And honestly, that analogy is perfect because it's the ultimate mechanical and physiological paradox.
Yeah.
For decades, the foundational comfort of cardiac surgery was just exposure.
Just seeing everything.
Exactly. I mean, if a valve was failing or an artery was blocked, the solution was brutal.
Yeah.
But it was conceptually simple. You do a median sternotomy.
Right. You take a saw, you split the sternum from the notch down to the xiphoid process, and you crank the chest open.
Yeah, and suddenly the entire operative field is just right there in front of you, bathed in bright light.
Fully accessible to the surgeon's hands.
And completely visible to the anesthesiologist who's just peering over the ether screen.
It's comforting. You know, you can literally see the heart beating. You can watch the right ventricle fill.
Yeah.
And if something goes wrong, the surgeon can literally just reach out and put a finger on the bleeding vessel.
But that wide open hood, that massive exposure, it comes with a really devastating physiological price tag.
Oh, absolutely. Massive tissue destruction.
Right, you're breaking a major bone, you're exposing raw bone marrow to the systemic circulation, and you're triggering this profound whole-body systemic inflammatory response syndrome.
Which is exactly why the evolution of this field has just been this relentless march toward smaller incisions, right?
Yeah, exactly. I mean, over the years, the surgical community moved from full sternotomies to partial or, mini sternotomies,
Right.
and then to small thoracotomies between the ribs, and finally to totally endoscopic and robotic approaches.
Just trying to spare the patient that massive inflammatory hit.
That's the goal, always.
And as a postgraduate student preparing for this exam, you are going to be tested intensely on this shift.
Oh, heavily.
Because here is the brutal reality. The surgeon's minimally invasive dream is basically the anesthesiologist's physiological nightmare.
It really is. You're trading surgical trauma for immense anesthetic complexity.
So today, we're stepping into our roles as your senior MD anesthesia faculty to guide you through this.
We're going to dissect the surgical techniques, the frankly terrifying physiological tightropes you have to walk, and the precise anesthetic management of MICS.
Right. Minimally invasive cardiac surgery, including keyhole bypass surgery.
We'll give you the exact examiner-centric terminology, the high-yield physiological mechanisms, and the structured frameworks you actually need.
Yeah. Whether you're facing a 20-mark long essay question or a really high-pressure Viva station or an OSCE on lung isolation devices, you'll know exactly how to structure your answer.
So let's start by defining our terms, because in a Viva, the opening definition really sets the tone for the entire interrogation.
Totally. If an examiner asks you, "Doctor, define minimally invasive cardiac surgery," you don't want to just fumble around with vague descriptions of small cuts.
No, absolutely not. You need a crisp, exam-ready definition, and the most precise definition is actually a negative one.
Okay, lay it out for us.
For your exam, you state that minimally invasive cardiac surgery is defined as any cardiac surgical procedure performed without a full standard median sternotomy.
So it's defined by what it avoids.
Exactly. And furthermore, it frequently utilizes cardiopulmonary bypass support established via peripheral cannulation.
Like the femoral vessels.
Right. Rather than the traditional central cannulation of the aorta and right atrium.
Okay, so no full sternotomy. Now, if we narrow that focus specifically to keyhole bypass surgery, which the literature usually calls minimally invasive CABG.
In that case, you're specifically referring to coronary revascularization that's performed through small thoracotomy incisions.
It's like a left anterior mini thoracotomy.
Exactly. Or through completely closed chest endoscopic ports. But again, the unifying theme is the absolute avoidance of splitting the sternum.
Got it. Now, before we get into the terrifying physiology, let's lay out the benefits.
Right.
If a 10-mark question asks you to list the advantages of MICS, what's the structured list you need to put on that paper?
You want to list these sequentially,
Yeah.
moving from the immediate postoperative period to long-term recovery.
Makes sense. So, number one.
First, drastically reduced postoperative pain, because obviously we haven't broken the sternum.
Right.
Second, a significantly lower incidence of deep sternal wound infections.
Which is huge. Avoiding mediastinitis is a massive victory.
It really is, as that complication carries a very high mortality rate.
Yeah. Okay, third.
Third is preservation of the chest wall's structural integrity. That allows for a much faster return to normal pulmonary mechanics.
Because the bellows of the chest still work.
Exactly. Fourth, a faster return to normal daily activities for the patient. Fifth, shorter ICU and overall hospital stays, which, is a major economic driver for the hospital.
Oh, for sure. Administration loves that.
Yeah. And finally, the improved cosmetic outcome, which, while it's secondary to survival, it's highly valued by patients.
Okay, so smaller scar, less bone pain. Great. But let's look at how the examiners are going to classify these procedures.
Right.
If I'm the examiner and I say, classify the types of minimally invasive cardiac surgeries, how do you organize that answer so it doesn't just look like a random alphabet soup of acronyms?
You really want to categorize them by the surgical approach and the specific goal of the operation. Let's start with coronary revascularization.
Okay.
The first major category is MIDCAB, minimally invasive, direct coronary artery bypass.
Let's pause on MIDCAB. Because if the goal is to bypass a blocked coronary artery without cracking the chest, how is the surgeon physically getting to the heart?
Yeah, they aren't just poking around blindly in the dark.
I'd hope not.
No, they use a very specific anatomical window. For a MIDCAB, the surgeon makes a small left anterior thoracotomy.
So just between the ribs?
Exactly. Usually a 5 to 7 centimeter incision between the ribs on the left side of the chest.
Right.
Through this small window, they harvest the left internal mammary artery, or lima, from the inside of the chest wall.
And
then they anastomose or sew that lima directly onto the left anterior descending artery, the LAD.
And crucially for the exam, you have to note that MIDCAB is usually performed off-pump, right?
Yes, very important. It's an OPC cab procedure, off-pump coronary artery bypass.
Yeah.
The heart is literally still beating while they sew.
That is wild. Okay, so MIDCAB is basically a smaller window for a very specific target, the LAD.
Correct. Yeah.
But let's move to the extreme end of the spectrum. I consider this a massive exam focus. Write this down, highlight it, put a huge asterisk next to it, TECAB.
Oh, absolutely. Total endoscopic coronary artery bypass.
That's like the absolute frontier.
It is. It's completely endoscopic. There is no thoracotomy incision at all.
No.
The surgeon operates entirely through small, closed chest ports using a robotic-assisted system, like the Da Vinci robot.
The surgeon isn't even scrubbed in at the table.
Right. They're sitting at a console in the corner of the room, looking at a 3D monitor and just manipulating robotic joysticks.
And unlike MIDCAB, which is almost always off-pump, TECAB has variations, right?
It does. TECAB can be performed either off-pump on a beating heart or on-pump.
But if it's done on pump, the chest is closed, so how do they bypass?
Well, the cardiopulmonary bypass must be established peripherally, usually through the femoral vein and artery.
Okay, so we have MIDCAB and TECAB for coronary disease. What about the valves?
We have a whole category for minimally invasive valve surgeries. These don't use the robotic ports, but rather smaller strategic bone cuts.
Like a mini sternotomy.
Right. For an aortic valve replacement, or AVR, the surgeon might use an upper partial sternotomy, a mini sternotomy that only splits the top half of the bone.
And for mitral valves?
For mitral valve surgery, they typically use a right mini thoracotomy, approaching the mitral valve from the right side of the chest.
Okay. And we should also create a category for port access cardiac surgery, right?
Definitely. That heavily utilizes peripheral bypass and endoscopic visualization for things like atrial mass removals or closing septal defects.
Right. And finally, just to be thorough in your classification for the examiner, you can briefly mention transcatheter procedures.
Yeah, like TAVI transcatheter aortic valve implantation or the MitraClip.
But we should add a caveat there for the examiner, right?
You have to. While TAVI and MitraClip are minimally invasive because they're catheter-based, they're generally classified under structural heart interventions managed in the cath lab.
Right, rather than classic surgical MICS managed in the main operating room.
Exactly.
All right, let's stop and look at the big picture here, because there's a really profound paradox at the heart of MICS, and it's a point of nuance that separates the average student from the gold medal candidate.
Yeah, it really does.
The term minimally invasive is actually kind of a surgical marketing term.
It absolutely is.
It refers strictly to the incision on the skin. It does not mean a minimal physiological insult.
That is exactly the point you must make in your exam.
Yeah.
You are trading surgical trauma for profound physiological complexity.
Right.
Because the surgeon is operating through a tiny keyhole or, using robotic arms remotely, the technical difficulty of the surgery just skyrockets.
Yeah.
As a result, The cardiopulmonary bypass times and the aortic cross-clamp times in MICS are often significantly longer than in conventional open surgery.
Which means the systemic inflammatory response from the bypass machine itself can actually be worse, even though the bone wasn't broken.
Precisely. And the anesthetic management goes from being a relatively straightforward exercise in maintaining hemodynamics to this crazy high-wire balancing act.
Involving intentional lung collapse, artificial pneumothoraces, and these really complex peripheral perfusion strategies.
It's a lot.
That brings us right into Part C, the surgical and physiological considerations. Let's really dig into the surgical approach in a keyhole CABG.
Let's do it.
Because understanding the surgeon's limitations is the only way to understand your anesthetic goals. They access the heart between the ribs. This limits their surgical exposure severely.
Right. They can't easily see the posterior wall of the heart. They can't see the inferior wall.
And because the surgeon is essentially blind to anything not directly in front of their small incision or their endoscopic camera, the anesthesiologist steps into a completely new role.
You're no longer just managing the vital signs. You become the literal eyes of the surgical team.
Using transesophageal echocardiography, or TE.
Exactly. You are navigating the hidden anatomy for them.
Let's dial in on TECAB, the total endoscopic CABG, because this is where the physiology gets truly wild. And it is very high yield for the exam.
It's very high yield.
The surgeon is at the console. The robotic arms are inserted through ports in the left side of the chest. But a human chest cavity isn't an empty cavern.
Right. It's packed full of lungs and heart.
So how do the robotic arms even have room to move, let alone harvest an artery from the chest wall?
Well, they don't have room. And this is the first major physiological insult we inflict on the patient. The absolute requirement of one lung ventilation, or OLV.
To give the robotic arms space.
Yes. To harvest the left internal mammary artery, the entire left lung must be completely deflated and literally tucked out of the way.
We'll talk about exactly how we isolate that lung later, but for now, just imagine it. The left lung is flat.
Yeah.
But even if the lung collapsed, the surgeon often complains they don't have enough working space.
They always want more space.
Right. The pericardium is still in the way, the mediastinum is crowded. So to create an artificial cavern inside the thorax, the surgeon insufflates the chest with carbon dioxide.
And this is a critical exam concept. If you connect this to the broader surgical world, it is exactly the same principle as a laparoscopic cholecystectomy, where they blow up the abdomen with CO2.
But here we're doing it inside the thoracic cavity.
Right. You need to know the parameters for the Viva. The surgeon will insufflate CO2 at a flow rate of 5 to 10 liters per minute, aiming for a maximum intrapleural pressure of 5 to 10 millimeters of mercury.
Wait, let's think about that from an anesthesia standpoint. You're taking a closed chest cavity and intentionally pumping it full of pressurized gas.
Yeah.
You are deliberately creating a massive tension pneumothorax.
You really are.
In the emergency room, we are taught to decompress a tension pneumothorax immediately because it's a lethal emergency. Here, we're treating it as a surgical requirement. What does that do to the patient's hemodynamics?
Oh, it creates a total cascade of hemodynamic compromise. When you pressurize the right or left pleural space with 10 millimeters of mercury of CO2, that pressure transmits directly to the compliant structures in the mediastinum.
Primarily the veins.
Primarily, yes. It compresses the superior and inferior vena cava.
So venous return to the right atrium drops off a cliff.
Exactly. Preload plummets. According to the Frank-Starling curve, if you dramatically decrease ventricular end-diastolic volume, your stroke volume and cardiac output will instantly fall.
But that's only half the problem, right?
Right. Because that same CO2 pressure is also compressing the pulmonary vasculature in the remaining ventilated lung.
Oh, wow.
Which massively increases right ventricular afterload.
Let me summarize that because it is vital for the listener. You are simultaneously starving the right ventricle of blood because of decreased preload while forcing it to pump against a much higher resistance because of increased afterload.
Which can lead directly to acute right heart distension. The right ventricle dilates, the interventricular septum physically bows into the left ventricle.
Which impairs left ventricular filling.
Exactly, leading to a catastrophic drop in systemic blood pressure and ultimately cardiovascular collapse.
And this is all happening while the surgeon is sitting at a console across the room.
Yeah, they're not even at the table.
If that heart fibrillates or bleeds under that tension pneumothorax, the surgeon cannot just drop a scalpel and plunge their hands into the chest.
Which is why the anesthetic team must have a rehearsed, flawless protocol for emergency crash conversion to a full sternotomy. We'll detail that protocol later, but you must signal to the examiner that you understand the precarious nature of this setup.
Let's synthesize this into what we can call the triad of insult. This is pure gold for your Viva.
Love that phrase. Triad of insult.
If the examiner asks you, Doctor, what are the primary physiological challenges the patient faces during a totally endoscopic cardiac surgery? You don't just ramble.
No.
You structure your answer around this triad. Number 1, extreme positioning. Number 2, one-lung ventilation. Number 3, CO2 insufflation.
Let's break down the mechanics of each insult. First, positioning.
Okay.
To help gravity pull the deflated lung and abdominal contents out of the surgical field, the patient is often placed in a steep Trendelenburg position.
Head down.
Head down, combined with a lateral decubitus tilt with the operative side rolled up.
So the patient is tilted back and rolled to the side. What happens to the lungs?
Well, the heavy abdominal viscera like the liver, the bowels, they slide cephalad, pushing forcefully against the diaphragm.
Right.
This drastically reduces the functional residual capacity, or FRC, of the remaining ventilated lung. The lung literally becomes stiffer, pulmonary compliance drops.
So you have to push harder to get the same tidal volume into that lung.
Exactly.
Okay, that's insult 1. Insult 2. One lung ventilation. We've dropped the left lung to give the robot space.
By completely collapsing one lung while the right ventricle continues to pump unoxygenated blood through it, you are intentionally creating a massive right-to-left intrapulmonary shunt.
Because blood is traversing the pulmonary circulation without picking up oxygen or offloading CO2.
Right. This inherently drives the patient toward hypoxemia.
And finally, insult 3, the true wild card, CO2 insufflation. We've already talked about the mechanical pressure, the tension pneumothorax effect on venous return and right ventricular afterload, but there's a whole second layer to this, right? The biochemical effect.
Absolutely. Carbon dioxide is highly soluble. When you pump it into the pleural space, it diffuses rapidly across the pleura and directly into the bloodstream.
Which leads to?
This inevitably leads to systemic hypercarbia and respiratory acidosis.
Now, how does the body react to that sudden spike in arterial CO2? It's kind of a fascinating double-edged sword that you need to be able to explain clearly.
Hypercarbia has two opposing cardiovascular effects. Directly, at the cellular level, elevated CO2 and the resulting acidosis actually depress myocardial contractility.
It makes the heart muscle weaker.
Yes. However, indirectly, hypercarbia triggers a massive stimulation of the central sympathoadrenal system. It causes a huge release of endogenous catecholamines, epinephrine, and norepinephrine.
So you have a direct depressant fighting against a massive sympathetic adrenaline surge. Who wins?
Well, in a healthy, robust patient, the sympathetic surge easily overrides the direct depression. The clinical picture you see on the monitor is a net tachycardia and hypertension.
The heart races and blood pressure spikes.
Yeah.
But, and this is the crucial caveat for the exam, we aren't operating on healthy, robust patients, are we? We are operating on patients with severe coronary artery disease.
Exactly. Imagine a 70-year-old patient with poor left ventricular function who is heavily beta-blocked to control their angina.
Oh, man.
When you insufflate the chest with CO2, their depleted sympathetic nervous system cannot mount a surge, or the beta blockers prevent the heart from responding to it.
So in this patient, the sympathetic response is completely blunted.
Yes, the direct myocardial depression takes over entirely. Combined with the decreased venous return from the mechanical pressure, you'll witness profound sudden hypotension and cardiovascular collapse.
So as the anesthesiologist, you're staring at the monitor, watching the CO2 climb, watching the pressure drop. What are your implications? Your instinct is to clear that CO2 by increasing minute ventilation, right?
Just turn up the respiratory rate and blow it up.
It acts, your hands are tied.
They are completely tied. Because you only have one functioning lung. You have to increase minute ventilation, but you must keep peak airway pressures low, usually strictly below 30 centimeters of water.
Because if you aggressively hyperventilate that single dependent lung,
the high pressure will cause barotrauma, volutrauma, and shear stress, leading to devastating ventilator-induced lung injury.
It's an excruciating balancing act. You are forced to accept a degree of hypercarbia just to protect the lung.
Exactly.
Because we're literally collapsing a lung, crushing the FRC with positioning, and blowing up the chest cavity with CO2 like a balloon. You can't just put anyone on this table.
No, definitely not.
If a patient's lungs or heart are already severely compromised, this specific physiological gauntlet will kill them. Which brings us to Part D, the hardest part of the anesthesiologist's job, preoperative assessment and patient selection. This is absolutely essential.
The preoperative evaluation for MICS involves everything you would do for standard ischemic heart disease, assessing the severity of the coronary artery disease, evaluating left and right ventricular function via echocardiography, and identifying any valvular lesions.
Right, but the absolute critical differentiator for the exam is the pulmonary function assessment.
You must prove to the examiner that you understand how to evaluate a patient for one lung ventilation.
You've described this in the past using a brilliant analogy: the three-legged stool of pulmonary assessment. If I'm writing a 20-mark essay, how do I lay out the stool?
You describe the three independent parameters that must be evaluated. Leg 1 of the stool is lung mechanics. You assess this via spirometry, looking at the forced expiratory volume in 1 second, the FEV1, and forced vital capacity, the FVC.
That basically tells you if the patient can physically move air in and out.
Exactly. Leg 2 is parenchymal function,
Which is evaluated using the diffusing capacity of the lungs for carbon monoxide, or DLCO. I want to stop here for a second because I sometimes forget the exact physiological implication of DLCO in the specific context. Why does the diffusing capacity matter so much before we isolate a lung?
It matters because of that massive right-to-left shunt we create during OLV.
Right.
When you collapse the left lung, all the oxygenation burden falls onto the right lung. If the patient has a terrible DLCO, meaning the alveolar capillary membrane in that right lung is thickened, scarred, or destroyed by emphysema, it won't matter how much oxygen you pump into the airway.
Because it can't cross over?
The oxygen physically cannot diffuse across the disease membrane fast enough to oxygenate the blood and compensate for the shunt. The patient will become profoundly, irreversibly hypoxic the exact moment you drop the operative lung.
That makes perfect sense.
Yeah.
Mechanics, parenchyma, and what's the third leg?
Leg 3 is cardiopulmonary interaction and reserve. We test this ideally with cardiopulmonary exercise testing, or CPAT. We're looking at the maximum oxygen consumption, the VO2 max. For lung isolation, a VO2 max greater than 15 milliliters per kilogram per minute is generally considered acceptable. It proves the heart and lungs can work together under stress.
Ultimately, you're synthesizing all three legs of this stool to answer one definitive question for the surgeon: suitability for OLV.
Yes.
Can this specific patient physically tolerate having one lung completely taken out of the ventilation equation while the remaining lung is subjected to surgical compression and CO2 insufflation?
Which naturally leads to a classic Viva trap regarding patient selection. The examiner will ask, "Doctor, if MICS provides such a wonderful cosmetic result and less pain, why don't we do it for every single cardiac patient?"
You must know the absolute and relative contraindications. But more importantly, you must explain the physiological rationale behind them. Do not just list them, explain the why.
Precisely. Let's walk through them. First contraindication: previous thoracic surgery on the operative side, or a history of severe pleural infections leading to dense pleural adhesions.
The rationale: well, if the lung is glued to the inside of the chest wall by scar tissue, the lung will not collapse when you try to isolate it.
Right.
If the lung won't collapse, the surgeon cannot get their endoscopic camera or robotic arms into the chest. The procedure is physically impossible.
Second contraindication: severe pulmonary hypertension, or severe chronic obstructive pulmonary disease, COPD.
The rationale here ties back to the triad of insult. A patient with severe COPD cannot tolerate the hypoxia of one lung ventilation.
Exactly.
And a patient with severe pulmonary hypertension already has a failing right ventricle. If you add the increased right ventricular afterload caused by the CO2 pneumothorax, you will precipitate acute right heart failure on the table.
Third contraindication:
Ah.
severe peripheral vascular disease, particularly aortoiliac disease.
The rationale: remember that for totally closed chest procedures on bypass, you must use peripheral cannulation. You have to slide massive, rigid venous and arterial cannulae up the femoral vessels. If those vessels are calcified, tortuous, or narrowed by severe atherosclerosis, you cannot establish cardiopulmonary bypass. If you try, you'll dissect the femoral artery, cause massive retroperitoneal bleeding, or shower the brain with embolic plaque.
If you explain those contraindications with that level of physiological depth, the examiner will know you are operating at a consultant level.
Okay. Assuming our patient passes the rigorous pre-op assessment, we wheel them into the OR. This brings us to a very high-yield section of the exam: Part E, monitoring.
Right.
Because we were flying blind in a closed chest, our monitors are a lifeline. Standard monitors are a given 5-lead ECG with continuous ST segment trending to watch for ischemia, pulse oximetry, capnography, core temperature monitoring. But let's talk about arterial lines.
Oh, this is a big one.
Because there is a legendary exam-failing trap here, specifically regarding the TECAB procedure.
This is critical. Pay close attention. If you're asked to describe the anesthetic setup for a totally endoscopic CABG that utilizes an endoaortic occlusion balloon clamp, and you confidently state, I will place a right radial arterial line for continuous blood pressure monitoring, you will lose massive marks.
Yeah.
In many Vivas, that is an automatic fail. You must explicitly specify that you will place bilateral radial arterial lines, both the left and the right wrist.
I want to build the tension on this because it's such a brilliant physiological catch. Why both? What are we looking for?
To understand why, you have to visualize the anatomy in the endoaortic occlusion balloon clamp, the AOBC. In a closed chest bypass, the surgeon cannot put a physical metal clamp across the aorta to isolate the heart. Instead, the perfusionist threads a specialized catheter from the femoral artery all the way up the descending aorta, over the aortic arch, and into the ascending aorta. At the tip of this catheter is a balloon. When inflated, this balloon occludes the ascending aorta, doing the job of a metal cross-clamp. It separates the heart from the systemic circulation, so cardioplegia can be delivered to stop the heart.
So the balloon is sitting in the ascending aorta, just distal to it, just downstream from the heart, is the aortic arch, which gives off its major branches.
Yes.
The very first branch off the arch is the innominate artery, which goes on to supply the right arm and the right side of the brain.
Exactly. The margin for error is measured in millimeters. The balloon must sit perfectly between the coronary ostia and the innominate artery. But during the procedure, as the robotic arms push and pull on the heart, that balloon can migrate.
And if the balloon migrates proximally, even slightly, it will cover the origin of the innominate artery.
And if it covers the innominate artery, it instantly shuts off all arterial blood flow to the right arm and catastrophically to the right cerebral hemisphere.
This is why the bilateral arterial lines are your early warning system. If you only have a right radial line and it goes flat, you might just think the line kinked or the patient's systemic pressure dropped.
Right.
But if you have bilateral lines and suddenly the left radial trace is showing a beautiful bounding pressure of 120/80, while the right radial trace goes completely flat, you have instantly diagnosed innominate artery occlusion.
You know the brain is currently starving of oxygen. You immediately shout to the perfusionist to deflate the balloon, pull it back 1 centimeter, and reinflate. That single monitor setup saves the patient from a massive intraoperative stroke.
That is the exact level of mechanistic detail the examiner wants. What about central venous access?
You'll place a large-bore, multi-lumen central venous catheter, typically in the right internal jugular vein. Pulmonary artery catheters, or Swan-Ganz catheters, are used selectively based on the patient's baseline right heart function and the institutional protocol, as they can sometimes interfere with the peripheral venous bypass cannulae.
But let's move to the absolute superstar of MICS monitoring. The unquestionable cornerstone of this entire specialty, transesophageal echocardiography. T.
You cannot overstate the importance of T in this exam. In conventional open-heart surgery, T is a fantastic diagnostic tool to check the valves or ventricular function. But in minimally invasive surgery, T transforms into a primary, indispensable navigational instrument.
Right. The anesthetist manipulating that probe is the only person who can see what's happening inside the great vessels.
Exactly. If the examiner asks, what is the specific role of T in my class, you need a structured list.
What are the key points?
First, navigation of cannulae. You must use the T to visualize the guide wires and the massive venous and arterial cannulae as they are advanced from the groin into the right atrium and aorta. You ensure they don't slide into a false lumen, go down the hepatic vein, or puncture the delicate atrial wall.
Vital. Second,
precise positioning of that endoaortic balloon we just talked about. You use the T to confirm the balloon is safely seated above the aortic valve and below the innominate artery. Third, continuous monitoring for myocardial ischemia. Because the surgical manipulation and the pneumothorax can drastically alter the electrical axis of the heart, your ECG-ST segment trending might become unreliable.
Oh, that makes sense.
Key allows you to watch the actual muscle in real time. You're looking for new regional wall motion abnormalities, a segment of the left ventricle that suddenly stops squeezing, which is the earliest sign of ischemia.
Fourth,
assessing right ventricular function. You use the T to watch the right ventricle as the surgeon insufflates the CO2. If you see the right ventricle ballooning out and the septum bowing leftward, you know the pressure is too high. And you tell the surgeon to back off the insufflation flow.
And finally,
A crucial safety check.
yeah,
Confirming complete de-airing of the heart before weaning from cardiopulmonary bypass.
right. Because in a conventional sternotomy, when it's time to restart the heart, the surgeon can physically lift the apex of the heart, massage it, and put a needle in the top to vent out any trapped air bubbles.
But in MICS, the surgeon cannot touch the heart. They rely entirely on the anesthesiologist to meticulously scan all 4 chambers and the aorta with a T to ensure absolutely no microbubbles remain before the heart is allowed to eject blood into the systemic circulation.
If you miss a bubble, it goes straight to the brain.
It's an immense responsibility. The anesthetist is truly the co-pilot of the surgery here.
All right, our monitors are on, our A-lines are in, the T-probe is ready. We move to Part F, anesthetic management. Let's talk induction of anesthesia.
Your core goals during induction in any cardiac patient remain the same. Preserve the delicate balance of myocardial oxygen supply and demand.
Right. You must fiercely prevent tachycardia, which increases demand and decreases diastolic filling time for the coronary arteries. And you must prevent hypertension or profound hypotension.
The technique requires a smooth, cardiostable induction. You're typically using a balanced technique, a high-dose opioid-like sentinel for profound analgesia and blunting of the intubation response.
A benzodiazepine like midazolam.
Right. Carefully titrated doses of a hypnotic like etomidate or propofol, depending on ventricular function, and a non-depolarizing muscle relaxant like rocuronium.
However, the unique challenge here is that as you push those induction drugs, you must be mentally prepared for a complex airway scenario. Placing lung isolation devices is inherently more difficult, takes longer, and requires more manipulation than sliding in a standard single-lumen endotracheal tube.
Which perfectly sets up our next massive exam topic.
Yeah.
Airway management and lung isolation. This is absolutely essential for your Viva. We established earlier that we must drop the left lung to give the robot space.
Right. You have 2 primary tools to achieve one lung ventilation: the double lumen tube, or DLT, and the bronchial blocker. How do you analyze the choice between them for the examiner?
You need to compare them practically. The double lumen tube is widely considered the gold standard for adult thoracic and minimally invasive cardiac cases. It's essentially 2 tubes fused together, one ending in the trachea, the other extending down into the main stem bronchus.
And its major advantage.
It offers rapid, reliable deflation of the operative lung. Furthermore, because it has 2 separate large internal lumens, you can easily pass a suction catheter down the collapsed lung to clear secretions or blood, or you can apply continuous positive airway pressure, CPAP, directly to that isolated lung if the patient becomes hypoxic.
But the DLT is massive. It's rigid, bulky, and difficult to place, especially if the patient has a challenging airway anatomy.
Which is precisely where the bronchial blocker shines. A bronchial blocker is a long catheter with a small balloon at the tip that is passed either through or alongside a standard single-lumen endotracheal tube.
Right. You use a bronchoscope to guide the balloon into the main stem bronchus of the lung you want to collapse, and then inflate the balloon to plug the hole.
Exactly. So the advantages of the blocker. It is highly useful if the patient has a known difficult airway, because you just secure the airway normally with a standard tube first, then worry about placing the blocker.
Makes total sense.
Secondly, it's ideal if you know the patient is going to remain intubated postoperatively in the ICU. With a DLT, you have to perform a risky tube exchange at the end of a long edematous case to put in a standard tube. With a blocker, you just deflate the balloon, pull the blocker catheter out, and leave the standard endotracheal tube perfectly in place.
Now, regardless of whether you choose the DLT or the blocker, the examiner is going to ask for your immediate next step after securing it. What is mandatory?
Fiber optic bronchoscopy. It is absolutely mandatory to visually confirm the correct anatomical placement of your DLT or your bronchial blocker using a flexible fiber optic bronchoscope. You cannot rely on auscultation alone.
And here's a crucial nuance for the exam. You confirm it once after intubation while the patient is flat on their back. But then the nursing staff rolls the patient into that steep lateral decubitus position for the surgery.
And when you roll a paralyzed patient, gravity and shifting mediastinal structures almost guarantee the tube will move. Malpositioning of the lung isolation device during patient positioning is a common, disastrous, and highly testable complication.
Right. A DLT that was perfectly seated in the left mainstem can back out into the trachea, and suddenly you're ventilating both lungs again, just as the surgeon is trying to dock the robot.
You must explicitly state in your exam, I will re-verify placement with the fiber optic bronchoscope after the patient is in the final surgical position.
That attention to detail is what earns the distinction mark.
Okay.
The patient is positioned, the lung is isolated, the surgery begins. Let's talk intraoperative management, specifically your ventilation strategy on that one remaining functioning lung.
You are operating with zero margin for error here, so you must employ rigorous lung protective ventilation strategies. You are ventilating the dependent lung, the lung physically lower to the ground. Tidal volumes should be strictly limited to 4 to 6 milliliters per kilogram of ideal body weight.
But wait, if we are using tiny tidal volumes on only half the lungs and the surgeon is pumping CO2 into the chest, the arterial CO2 is going to skyrocket. We talked about this earlier. We want to blow it off, but we can't.
Exactly. And this is where you introduce the concept of permissive hypercapnia to the examiner. Because of the limited lung volume available, you will likely need to tolerate a rising CO2 and a dropping pH.
Right.
You permit the hypercapnia, allowing the pH to drop down to around 7.25 in order to avoid increasing the respiratory rate or tidal volumes to a point where the peak airway pressures exceed 30 centimeters of water. Protecting that single functioning lung from barotrauma takes precedence over a perfectly normal blood gas.
Let's run a clinical scenario, because this is a guaranteed Viva question. You're an hour into the TECAB. The patient is on one lung ventilation. Permissive hypercapnia is established. Suddenly, the pulse oximeter starts dropping. 94%, 90%, 88%. The low oxygen alarm starts ringing. The examiner asks, "Doctor, walk me through your hypoxia algorithm during OLV."
This is a structured crisis management answer that you must have memorized step by step.
Okay, step 1.
Step 1. Increase the inspired oxygen concentration, the FiO2, to 100%. Simultaneously, grab your fiber optic bronchoscope, pass it down the tube, and check the position. The most common cause of sudden hypoxia is that the DLT or blocker has dislodged.
Step 2.
Step 2. Optimize hemodynamics. Look at your arterial line and cardiac output. If the cardiac output is dropped, perhaps due to the CO2 insufflation, the mixed venous oxygen saturation drops.
Oh, right.
When that extremely desaturated blood crosses the intrapulmonary shunt in the collapsed lung, it profoundly exacerbates the systemic hypoxemia. You must restore cardiac output with inotropes, or by asking the surgeon to lower the CO2 pressure.
Makes sense. Step 3.
Step 3. If the tube is perfect and hemodynamics are stable, you apply CPAP, continuous positive airway pressure, to the non-dependent operated collapsed lung. You connect a specialized circuit to the collapsed lung's lumen and apply 2 to 5 centimeters of water pressure with 100% oxygen.
That doesn't inflate the lung enough to bother the surgeon, but it allows some oxygen to diffuse across the massive shunt.
Precisely. Step 4.
Yeah, what if that doesn't work?
It's still hypoxic. Apply PEEP positive and expiratory pressure to the dependent ventilated lung to recruit microatelectasis and improve VQ matching.
And if all else fails, step 5.
Step 5. If all medical maneuvers fail and the patient is suffering critical ischemia, you must communicate with the surgeon. They must temporarily stop operating and either allow you to intermittently inflate the collapsed lung, or they must physically clamp the surgical pulmonary artery to entirely cut off blood flow to the collapsed lung, thereby eliminating the shunt.
That is a phenomenal stepwise answer. Moving on from ventilation, don't forget your temperature and fluid management. Because you are terrified of causing pulmonary edema in that single, hard-working dependent lung, you employ a highly restrictive intravenous fluid strategy.
Yes, and strict temperature management is vital, utilizing forced air warmers and fluid warmers, especially considering the prolonged operative times of robotic surgery.
Let's shift into Part G, special anesthetic considerations. These are the logistical nightmares entirely unique to MICS that examiners want to see you recognize.
First up, limited access. Think about the physical space in a conventional open-heart room. The anesthesiologist is at the head of the bed, the chest is open. If you need to check an IV, you reach out.
Right. But in a robotic TECAB, once the massive robotic heart is rolled in and the arms are docked into the patient's chest, a literal physical barrier is created.
The robot towers over the patient. The anesthesiologist physically cannot reach the patient's airway, the central lines of the neck, or the chest. Therefore, before the robot is ever brought to the table, every single vascular line must be impeccably secured with sutures.
Long extension tubing must be added to all IV lines so you can push drugs from a distance.
The endotracheal tube must be tied down with absolute security. If the line disconnects under the sterile drapes while the robot is docked, you cannot get to it.
Second unique challenge, defibrillation. In an open sternotomy, if the heart goes into ventricular fibrillation upon reperfusion, the surgeon calmly asks for the internal paddles, places them directly on the epicardium, and delivers a shock. You cannot use internal paddles if there's no open chest. I can literally hear an examiner shouting that in Aviva.
Precisely. Because the chest is closed, the surgeon has no access for internal defibrillation. Therefore, radiolucent external defibrillation pads must be firmly adhered to the patient's chest and back before the surgical draping even begins. If the heart fibrillates, you, the anesthesiologist, control the defibrillator from the console.
Third major logistical challenge, emergency conversion. This is the dark cloud hanging over every minimally invasive case.
Despite all the technology, things go wrong. A robotic instrument can tear the pulmonary artery. The endoaortic balloon can rupture the aorta. Because the surgeon is operating through tiny ports, they cannot just plunge their hand in to hold pressure on a catastrophic bleed. They must convert to a full open median sternotomy to save the patient's life.
And they don't have minutes to do this. They have seconds.
Which means the entire operating room team must have a rehearsed, explicitly communicated protocol for a crash conversion. Blood products must be fully cross-matched and physically sitting in a cooler in the room. And most importantly, a heavy-duty sternal saw must literally be sitting on the sterile back table, plugged into the power source, ready to be handed to the surgeon the instant the robotic cart is rolled back.
You must state in your exam that you will confirm the presence of that saw during the pre-induction briefing.
Definitely. Let's also detail the role of cardiopulmonary bypass in MICS. We've touched on it, but let's consolidate it. Unlike open CPB, where the surgeon directly cannulates the right atrium for venous drainage and the ascending aorta for arterial return, MICS requires peripheral cannulation.
Yes, the perfusionist and surgeon will typically expose the femoral vein and femoral artery in the groin. However, sliding a long venous cannula all the way from the groin up into the right atrium creates immense resistance. Drainage is often really sluggish.
So how do you ensure the bypass machine gets enough blood to run?
Two strategies. First, the anesthesiologist will often place a supplementary venous drainage cannula percutaneously into the right internal jugular vein in the neck to help drain the superior vena cava. Second, the perfusionist will employ kinetic venous, often vacuum-assisted venous drainage, or VAVD, applying negative pressure to the bypass reservoir to actively suck the blood out of the venous system.
Excellent. We've survived the surgery. We've successfully navigated the lung isolation, the tension pneumothorax, the peripheral bypass. The robot is undocked. The chest ports are closed. We move into Part H, postoperative management.
Because we intentionally avoided splitting the sternum to spare the patient that massive trauma, the postoperative anesthetic goal shifts aggressively to fast-track anesthesia. The goal is early extubation, either right there on the operating table before leaving the OR or within a very few hours of arrival in the intensive care unit.
But you can't just pull the tube blindly. What are the clinical criteria you use to justify early extubation in these patients?
We teach a simple acronym, OWAG. To be extubated, the patient must be alert, warm, and comfortable. They must be hemodynamically stable, generating adequate spontaneous tidal volumes, and most importantly, their pain must be under control.
And keeping them comfortable is a significant challenge. You might think, oh, it's just a tiny incision between the ribs, it won't hurt. But the intercostal space is packed with dense, highly sensitive nerve bundles. Torquing robotic trocars through those ribs for 4 hours causes severe intercostal neuralgia. A thoracotomy incision, pound for pound, is one of the most painful surgical incisions we make.
They are agonizing, which is why relying solely on intravenous opioids is a recipe for failure. If you push enough fentanyl or morphine to kill that severe rib pain, you will cause profound respiratory depression, hypercapnia, and completely ruin your chances of early extubation.
So what's the solution?
A rigorous multimodal analgesia approach. You must rely heavily on regional anesthesia techniques performed either preoperatively or intraoperatively under ultrasound guidance. This includes blocks like the erector spinae plane or ESP block, continuous paravertebral blocks, or meticulous intercostal nerve blocks placed directly by the surgeon from the inside of the chest before closing.
You layer those regional blocks with systemic non-opioid adjuncts. 4 via paracetamol, perhaps a ketamine infusion, and NSAIDs if the patient's postoperative renal function allows.
Perfect. Now, what about complications? In Aviva, if the examiner asks about the specific complications of MICS, how do you structure that answer to show mastery?
You don't just list generic surgical complications, you connect the specific complications directly back to the unique physiological insults we spend so much time discussing. This proves to the examiner that you understand the fundamental cause-effect relationship of the specialty.
Walk me through examples of that connection.
If the examiner asks for a respiratory complication, you say, hypoxia, resulting directly from the massive right-to-left interpulmonary shunt mandated by one-lung ventilation.
Makes sense. What if they ask for a cardiovascular complication?
You say, acute right ventricular failure resulting from the sudden increase in right ventricular afterload and decreased venous return caused by the CO2 insufflation mimicking attention pneumothorax.
Let's do a vascular one.
Femoral artery dissection or retroperitoneal hematoma, specific to the requirement of sliding massive rigid cannulae up the peripheral vessels to establish closed chest cardiopulmonary bypass.
And one more lung one, which is terrifying when it happens.
Unilateral re-expansion pulmonary edema. This can occur in the collapsed left lung upon rapid reinflation at the end of the procedure due to reperfusion injury and sudden alterations in alveolar surface tension. If you tie the complication to the pathophysiology, you own the viva.
We are entering the final stretch of your exam preparation. Part 1, comparison and exam integration. If you are sitting in the exam hall, pen in hand, looking at a 20-mark essay question asking you to compare MICS with conventional cardiac surgery, I want you to draw a mental 4-column table right now.
A clear, structured table is exactly what examiners are looking for. Column 1 is the feature, column 2 is conventional surgery, column 3 is MICS. Let's trace the key differentiators. First feature, incision.
Conventional, full median sternotomy, MICS, mini-thoracotomy, or totally endoscopic ports.
Second feature, cardiopulmonary bypass setup.
Conventional, central cannulation of the aorta and right atrium. MICS, peripheral cannulation, usually femoral, utilizing an endoaortic balloon clamp.
Third feature, lung management.
Conventional, standard 2-lung ventilation is almost always perfectly fine. MICS, 1-lung ventilation is an absolute non-negotiable requirement.
Fourth feature, pain and recovery.
Conventional, higher bone pain, prolonged period of sternal precautions and bone healing. MICS, less bony pain, faster return to mechanical baseline, faster hospital discharge.
Fifth feature, surgical and ischemic times.
Conventional, generally shorter due to excellent direct exposure. MICS, often significantly longer due to the extreme technical difficulty of remote endoscopic suturing.
That table alone is worth 5 marks. Now, what if they ask a more nuanced question? Compare MIDCAB specifically against conventional open CABG.
For that comparison, you focus heavily on the clinical indications and limitations. MIDCAB, the off-pump approach through the small left window, is the ideal procedure for a patient with isolated single-vessel disease of the left anterior descending artery, particularly when percutaneous intervention like a stent is anatomically inappropriate or has previously failed.
But conventional CAG remains the gold standard for diffuse, complex, multi-vessel coronary disease. The main limitation of MIDCAB that you must highlight is its inability to reach the posterior or inferior vessels of the heart, like the posterior descending artery or circumflex marginals. The window is simply too small.
Okay, let's consolidate everything into Part J, pure exam integration. We're going to go through the most common, devastating Viva traps so you can step right over them. Trap number 1, the A-line trap.
We discussed this in detail, but it bears repeating because it is a favorite among examiners. If you say, I will put in a radial arterial line for a robotic TECAB procedure using an endoaortic balloon, you fail the station. You must explicitly specify bilateral radial arterial lines to monitor for inadvertent innominate artery occlusion and impending cerebral ischemia.
Trap number 2, treating T as a generic diagnostic afterthought.
Students often list T and just say to look at the heart. In MICS, T is not just for looking. It is the primary navigational tool. You must specifically list its navigational uses, guiding peripheral guide wires, precisely seating the endoaortic balloon, and meticulously confirming complete de-airing before bypass separation.
Trap number 3, focusing only on the collapsed lung and ignoring the CO2 hemodynamics.
Students easily understand the hypoxia of a collapsed lung, but they forget that the chest is actively pressurized with CO2. You must describe the CO2 insufflation to the examiner as acting exactly like a physiological tension pneumothorax. You must explain how it crushes venous return and elevates right ventricular afterload, leading to right heart strain.
If you are structuring your 20-mark written answer, visualization and presentation are key. The examiner is tired, they've read 50 papers already. Make yours visually striking. Instead of just writing text, draw a simple labeled flow chart of your lung isolation setup, branching from patient airway assessment down to fiber optic confirmation.
Draw a simple cross-sectional diagram of a T view, a mid-esophageal long-axis view showing the ascending aorta, and clearly draw the endoaortic balloon seated correctly between the aortic valve and the innominate takeoff. And absolutely recreate that clear comparison table we just discussed. Bullet points and tables show organized consultant-level thinking.
Let's do a rapid-fire summary. To wrap up this massive topic, let's fire off the high-yield, undeniable take-home points. Let's go.
1. The paradox of MICS minimal surgical trauma equals maximum physiological and anesthetic complexity.
Right.
2. One lung ventilation is absolutely mandatory. You must master the indications for DLTs versus bronchial blockers and the 5-step hypoxia algorithm.
Got it.
3. CO2 insufflation drastically alters hemodynamics by mimicking attention pneumothorax, crushing preload, and spiking right ventricular afterload.
Crucial point.
4. TE is an absolute necessity for navigation, monitoring the EAO-BC and de-airing the closed heart.
5.
5. Peripheral CPB requires immaculate preoperative vascular assessment to avoid catastrophic femoral dissection.
Almost there. 6.
Second, bilateral arterial lines are your indispensable early warning system for innominate occlusion and stroke.
And lastly, 7.
7. Fast tracking requires meticulous multimodal regional analgesia to avoid opioid-induced respiratory failure.
And to wrap up your 20-mark essay, you want to leave the examiner with a concluding thought that proves you see the whole picture. Here is a model conclusion paragraph you can literally script, memorize, and write at the very end of your exam paper. In conclusion, while minimally invasive cardiac surgery achieves its goal of significantly reducing surgical tissue trauma and accelerating postoperative recovery, it inherently shifts a substantial burden of physiological and technical complexity directly onto the anesthesiologist.
Perfect start.
True mastery of this subspecialty requires meticulous execution of one lung ventilation, expert manipulation of advanced transesophageal echocardiography for blind navigation, and a profound mechanistic understanding of the unique physiological derangements induced by extreme positioning and CO2 insufflation. Flawless multidisciplinary communication and rehearsed emergency conversion protocols remain paramount for safe and successful patient outcomes.
Honestly, if an examiner reads that paragraph at the end of your paper, you are getting distinction marks. It is a perfect, comprehensive summary of the anesthetic imperative.
We have covered the engine from the inside out through the tailpipe and back. Best of luck on your Gujarat University MD anesthesiology exams. If you understand the physiology we've discussed today, you have the analytical tools to ace any question they throw at you on this topic.
Absolutely. You've got this.
But before we sign off, I want to leave you with a final, provocative thought to mull over as you study. We've talked extensively about the immense cognitive load placed on the anesthesiologist during these robotic procedures, balancing the CO2 insufflation against airway pressures and managing the shunt fraction. Consider how the rapid evolution of artificial intelligence and automated robotic feedback loops might soon fundamentally change the way we manage these exact patients.
That's a wild thought.
Could the robotic console of the future, sensing the exact intrathoracic pressure it needs for its surgical arms, automatically and instantaneously interface with the anesthesia machine? Could an AI algorithm adjust your ventilator's tidal volumes, respiratory rate, and PEEP continuously, perfectly matching the surgical manipulation stroke for stroke, completely automating the permissive hypercapnia protocols we currently manage by hand?
It sounds like science fiction, but the data integration is already happening.
Keep pushing the boundaries of your clinical knowledge, because the future of this specialized field is going to be wildly, seamlessly interconnected. Keep studying hard, and we will catch you on the next deep dive.